or different instability signs. The first test that I'm going to look at on Mindy is the sulcus test. So I'm going to apply a downward force on her humerus, and I'm going to look to see if I see any sulcus here at the head of her humerus. So I'm just going to pull down, look for that, and then release her shoulder. The second test is with Mindy lying on her back. So go ahead and come on down here. Good. Okay. And then I'm just going to take her arm in a neutral position, and I'm going to look at anterior and posterior instability. So the first one, I'm going to apply a posterior force. So I'm going to push down on her shoulder to see if I feel any looseness in this end range. And then I'm going to do just the opposite for the anterior. I'm going to apply an anterior force from the back to see if I see any instability this way. And then the final test is the anterior apprehension. So what I'm going to do is externally rotate her shoulder. And if somebody's had a dislocated shoulder or they have instability, this is going to be a very uncomfortable position. So you're going to see some apprehension with her in this position. And then I'm going to do the same thing, but I'm going to provide a little bit of support anteriorly to see if it's better that way.
A thorough AMA Guides evaluation of the lower extremities requires a number of measurements. Let's start out by talking about leg length discrepancy. In order to measure the leg lengths, you can do an X-ray. That's probably the most accurate way, but if that's not available, then you go from the anterior superior iliac spine to the medial malleolus and take the measurement there. You do it 3 times to make sure you have consistency and accuracy, and that will tell you whether one leg is longer or shorter than the other. The next measurement that you can use while you still have the tape measure in your hand is for atrophy. In the thigh, the measurement is taken 10 centimeters above the patella with the muscles relaxed, and you put the tape measure around the thigh at that level and measure each side. You do the same at the calves at maximum circumference, and just let that leg relax. And over here, and let it relax. For manual muscle testing of the ankle dorsi and plantar flexors, you grab the distal leg with one hand and the top of the foot with the other. Ask the patient to pull up as hard as they can. Pull up hard as you can, and you try to break their strength. As we described earlier, there's grade 5, grade 4, and occasionally grade 3. This has to be done in a reliable fashion. If it's inhibited by pain, that doesn't count. If it's inhibited by range of motion of the ankle, that doesn't count. The same thing happens with plantar flexion. Push down like you're stepping on the gas as hard as you can, and you try to break that. Next, we're going to do motion of the hip. Measuring motion of the hip is important for the range of motion section. First of all, you do a little exercise. Have the patient warm up each hip a couple of times, and then internal and external rotation, and abduction and adduction. Then you ask the patient to fully flex the hip, and you take the measurement with the large size goniometer. You do this 3 times, once more, and a 3rd time. That's flexion. Now we do abduction. One of the arms of the goniometer is right down the middle, the other is over the hip joint, and then you bring that back, and you do it again, and you bring it back, and once more, please. and you do it again. And of course, you'll do this on both sides. Now, in order to get extension and internal-external rotation, the patient needs to roll onto their stomachs, needs to be prone. Can you roll over onto your stomach? And then, using the goniometer, you have them bend their knee, lift their thigh up, and take a measurement. And 2, and 3. For the internal and external rotation, this is internal rotation. They roll out like this. And again, please. And back up to straight, and once more. And now let's go the other way. This is external rotation. And to neutral, and 2, and once more. All right. Now roll back onto your back again. We're going to do adduction as well as abduction. And that is a little tougher to do. You have to keep the legs close to each other, but still clear the other leg. And back to neutral, and again. And back to neutral, and once more. The next measurement is a series of motions of the knee. Again, using the large goniometer, you line up at the center of flexion of the knee. Of course, the knee is a polycentric joint, but you can get pretty close. You ask for active flexion, and you do that 3 times, and once more. And if there is a flexion contracture, in other words, if the knee cannot fully extend, then what you do is you put your hand behind the knee, get it out as straight as you can, without injuring the patient, without creating pain, and then measure the angle that you get. Additionally, in the AMA guides, there may be impairment values for varus and valgus malalignment. So what you do is you line up with the goniometer down the tibial crest and down the femur and measure the varus and valgus angles. In this particular case, it's pretty much neutral. Next, while we're examining the knee, we check for ligament stability. In varus and valgus, you bend the knee maybe 15 or 20 degrees, get it as loose and relaxed as possible, and check for that bilaterally. Then you do a Lockman type maneuver, checking for sagittal instability. Another way of doing that is to have the patient flex their knees to about 90 degrees and stabilize the feet. One thing I like to do is actually sit on their feet and then grab behind here, put your thumbs at the joint line so you can feel any play in the knees, and grade the ligament instability as mild, moderate, or severe as outlined in the AMA guides. The next area to measure is the ankle and foot. For flexion and extension, or dorsiflexion and plantar flexion, you use the goniometer, take a reading, and then 2, and the third one. And for inversion and eversion, I have the patient roll prone again. Turn over onto your stomach, please. Use one of these inclinometers. Have the patient invert and take the reading, invert and take a reading, and number 3, and then evert and take a reading, evert, and the third one. You need to be careful that this maintains a vertical axis and doesn't swing around back and forth, because obviously that will degrade your readings, and you do that on both sides. The guides in figure 17-5 state that you should do plantar and dorsiflexion measurements with the knee in extension and with the knee in 45 degrees of flexion. You take 3 measurements in each location and consider both of them when arriving at your range of motion analysis of the ankle. For the toes, you use the small goniometer. You take the great toe metatarsal phalangeal joint flexion times 3, and you take the great toe metatarsal phalangeal joint extension times 3, and you can do the same thing with the little toe. Doing flexion, 1, 2, 3, and extension, 1, 2, and 3. Muscle strength testing of the knee is done by asking the patient to fully extend the leg and then grabbing behind the knee, trying to push down on the ankle and see if you can flex the knee at all. Again, the grade 5, 4, 3 system, et cetera, is utilized to classify whether or not there is weakness. That weakness doesn't count if there's pain involved, loss of motion involved, and things of that sort. Testing for knee flexors, let the leg drop, and then fight me as I try to pull it up. And don't let me pull it up. And that's how you check for knee flexion strength. It's important that the neurological examination of the lower extremities includes sensibility testing and motor testing, assuring that the results are reliable.
Our goal was to provide you with a learning resource that would enhance your ability to perform assessments that accurately reflect the impairment associated with an injury or illness. It is crucial that the measurements you obtain are performed as outlined in the AMA guides. We appreciate you joining us. Thank you.